Hello, my name is Duncan Lascelles, and I'm going to kick off this section where we are going to talk about pharmaceutical treatments. I'll start, and then Dr. Staffieri is going to talk about certain components of this. As an overview here, I'm going to start talking about some conventional treatments. Then Dr. Staffieri will talk about treating the central component of pain. Then he'll come back to me. I'll talk about future treatments, and we will both have some concluding messages as a kind of an overview of the use of pharmaceutical treatments. I think pharmaceutical treatments can be broadly divided into those that are acting in the periphery, so non-steroidals, Gropiprant, possibly Acetaminophen. Those that are acting more centrally, things like Tramadol, Amantadine, Gabapentinoids. And then we do want to touch on some future treatments that may be available in the next few years. So let's start with an overview of the conventional treatments. And here we're really talking about the non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatories in general tend to be cyclooxygenase inhibiting. We'll come on to the Gropiprants later and also Acetaminophen, but let's focus first on the COX inhibiting non-steroidals. These drugs are inhibiting the activity of cyclooxygenase 1 and or cyclooxygenase 2, and therefore decreasing the production of prostanoids or prostaglandins. The simple message used to be that COX-1 produced prostaglandins involved in constitutive processes, so housekeeping processes, homeostasis, and that COX-2 produced prostaglandins involved in pain and inflammation. And that's not quite true, because COX-2 can produce prostaglandins that are involved in homeostasis and protective functions, and COX-1 can produce prostaglandins involved in pain and inflammation. But we'll come back to more of that later on. In general, cyclooxygenase inhibiting non-steroidals are our first-line therapeutic approach. They are predictably efficacious. They reduce inflammation and thereby reduce pain. They reduce peripheral sensitization and thereby pain. Remember, inflammation in general is always connected to pain, and sensitization is always connected to pain. So by reducing inflammation and peripheral sensitization, they end up being predictably efficacious. Because of their effect in the periphery, they will also reduce central sensitization. Because of the fact that to varying degrees, they will reduce the production of prostaglandins, there is the risk of side effects, and we will come back to that. I guess an important clinical question is how do you use these COX inhibiting non-steroidals? How should we use? And I think there are two basic approaches, either intermittent or continuative use. And there are pros and cons to each. I think the main advantage that people see of intermittent use is the idea you're giving less drug and only give when needed. The big problem with that is that you don't get that cumulative beneficial effect of reducing pain consistently over time. And we'll talk more about that. The continued use of non-steroidals is really what we would recommend. You get better pain control, which means better mobility, muscle mass builds up, there's better joint mobility. Some people talk about there being a greater incidence of side effects, but there actually isn't. As long as the non-steroidal is well tolerated in the first couple of weeks, there is no increased incidence of side effects with longer term use. So this is an important slide. People like to use non-steroidals intermittently. Our strong recommendation is for continued use. And there are data to support this. Not a lot of data. This study is actually from Human Medicine, where they show that the continued use of celecoxib, as opposed to intermittent use, resulted in fewer flare-ups. So better pain control with continuous treatment and fewer flare-ups with continuous treatment. Acetaminophen is also classed as a non-steroidal anti-inflammatory, and it's often used as a first line of treatment when people have fever. The mechanism of action is actually not fully worked out. There may be a number of processes that acetaminophen interacts with. And it's, as well as having some peripheral effects, it also has central effects. Decrease in production of prostaglandins, maybe interactions with the serotonergic, opioidergic, and endocannabinoid systems. It is considered not to have any anti-inflammatory action, and yet there are a couple of publications by Maburo et al. From the late 1980s that would suggest it can have some anti-inflammatory action. So I think the message here is, it is used, it's a very old drug, but still we don't really know how it works, and we don't know the full extent of its anti-inflammatory or indeed its analgesic effects. Non-steroidals, now I've already mentioned non-steroidals are best if they're used long-term continually. And let's talk a little bit about that some more. Myself and John Innes performed a study. We reviewed the literature for information on safety and efficacy regarding longer-term use of non-steroidals versus shorter-term use. And what we found was that with the longer-term use of non-steroidals, and we looked at longer than 1 month versus up to 1 month use, with the longer-term use, we saw a progressive decrease in pain. So that's a benefit. So if you use these non-steroidals continuously, you get these progressive improvements, these cumulative improvements over time. So very strong clinical evidence of a benefit of this longer term use of non-steroidals. Also, what we found was that we did not see an increase in adverse events with longer term use of non-steroidals. And again, that goes back to my earlier comments. If the non-steroidals are tolerated well for the first couple of weeks, they're likely to be tolerated well long term. There are adverse events that can be seen. Honestly, we don't actually know the true incidence of adverse effects associated with non-steroidal use. But because of the utility of prostaglandins across a variety of mechanisms, the gastrointestinal function, renal function, platelet function, if you inhibit the production of those prostaglandins, there is the potential for seeing adverse events. At the kidney, just to drill down in a little bit more detail, the kidney prostaglandins are used, they are produced by the kidney under conditions of relative or absolute hypovolemia, so particularly around the time of surgery. Prostaglandins are produced at the kidney to help maintain normal renal perfusion. And so if you have hypovolemia, if you have hypotension, under those circumstances, you would not be wanting to administer COX-inhibiting non-steroidals that are going to inhibit the production of these protective prostaglandins. Prostaglandins, as I mentioned, also have beneficial, useful functions in the gastrointestinal mucosa. And I think this slide is useful because it illustrates the fact that it's both prostaglandins produced by COX-1 and COX-2 that play a role in the homeostasis of gastrointestinal mucosal function. So because of the risk of side effects, I think there's a desire by many clinicians to modulate the amount of non-steroidal that patients are receiving over time. And the benefit in terms of reducing adverse events is actually not proven there. However, we do recommend decreasing the exposure of an animal to non-steroidal over time. We do recommend dose reduction over time because the pain transmission system is bidirectionally plastic. So we've talked about how it can deteriorate with treatment, with effective treatment. That system can actually revert back to normal. So for example, this slide illustrates how on the left there, if you provide non-steroidals, you decrease pain. With that decreased pain, exercise can increase, and exercise in and of itself will decrease pain. Increased exercise helps with weight management, which in and of itself will decrease pain. So a number of processes going on here that will decrease pain. With that decreased pain, it means you can, at some point, decrease the requirement for non-steroidals. So our recommendation is to use non-steroidals at the recommended daily dose for 3 months, then reevaluate the patient and see if you can start dose reduction. There's no defined best way, known best way to do this. I actually prefer to increase the dosing interval, so to drop from daily dosing down to 3 or 4 full doses per week. So now let's move on and talk about the Piprants. These are still non-steroidal anti-inflammatory drugs, but they are non-COX inhibiting. They do not inhibit cyclooxygenase. The Piprants act further down on this pathway, the same pathway, the cyclooxygenase pathway, if you like, but they act further down. And this diagram here illustrates where they act. The Piprants inhibit the interaction of prostaglandin E2 with one of the receptors, the EP4 receptor. So these are EP4 receptor antagonists. They're still non-steroidal anti-inflammatories. And it's by inhibiting that interaction between prostaglandin E2 and the EP4 receptor that they have their analgesic action. Now, you might question, just going back to this slide here, you might question whether, if we are so specific in targeting this receptor, you might question whether we still see appropriate efficacy. And we do. So all of the clinical information at the moment, and this is a published clinical study looking at the efficacy of Grapiprant, all the published clinical information indicates that the Piprants are as efficacious as the COX inhibiting non-steroidals. And you can see here the success failure rate across the Grapiprant and placebo group in the study by Rajdera et al., published in Journal of Veterinary Internal Medicine. And we can compare that, comparing like for like, to a study done with carprofen, comparing carprofen to placebo. And you can see the success failure rates are very similar across those two studies. So the message here is that Grapiprant is as efficacious. In terms of the safety profile, 2 things I want to touch on. Firstly, what's called the target animal safety, performed in young, healthy beagle dogs who received multiples of the daily recommended dose for up to 9 months, which is a long time for a target animal safety study. No deaths were seen, and overall a very clean looking safety profile. So a very appealing safety profile there. When we move to the field study, so now we're looking at adverse events in the target population. What I mean by that are older dogs with osteoarthritis. You can see there's really no difference between the Grapiprant group and the placebo group across the adverse events, except for vomiting. There was more vomiting in the dogs that received Grapiprant. One important thing to note here is that even though there was more vomiting in this group, in no case was Grapiprant stopped. So these dogs vomited 1, 2, maybe 3 times. They were otherwise healthy and alert, and Grapiprant was continued to be administered. And so I think, that is what I have now moved to in my clinical use of Grapiprant. So overall, I think the data clearly indicate that Grapiprant is no better, but no worse than COX inhibiting non-steroidals with regards to efficacy. The safety profile looks very good, no unusual adverse events seen. In terms of how it's being used, its use is very popular in young dogs, I think partly because of the safety profile, and overall, it certainly seems to be doing well in the US market. I'm now going to hand over to Dr. Staffieri, and he's going to talk about treating the central component of pain.
When we talk about treating the central component of pain, we talk about that mechanism that goes from peripheral sensitization to central sensitization. So all the mechanisms that involved the central the central nervous system in terms of spinal cord and brain. As we know, osteoarthritis over the time with a continuous peripheral stimulation can determine the activation of the central system, and so central sensitization and hyperalgesia, and so the what is called pathological pain or maladaptive pain. Tramadol is one of the drugs that can be able to work on these components of pain. Tramadol is one of the most commonly used, especially in some part of the world, in veterinary medicine. In some countries like Italy, it is also registered for the use in dogs and cats. It is a partial mu agonist, so is an atypical opioid, but is also involved the inhibition of norepinephrine reuptake and the inhibition of the serotonin reuptake. There are also has been also described other mechanisms like activation alpha-2 adrenoceptor, neurokinin 1, muscarinic, nicotinic acetylcholine receptor, and NMDA receptor. The analgesic potency of tramadol is 10% that of morphine, is more or less comparable to that of Amantadine. And the good thing is that it's not under controlled substance, so it can be prescribed to the owner at home. These drugs is widely used in human medicine to treat the central component of pain, so it's kind of a partial or partial opioids effect, but this is characterized by a particular mechanism of action. In particular, the tramadol works not only as the primary component, but also it has active metabolites. In particular, the M1 metabolites that is produced after the metabolization of the drug at the level of the liver is 300 times more, has 300 times more affinity for the mu receptor compared to tramadol. Then we have other metabolites, active metabolites that have been evaluated and discovered, M2, M3, M4, M5, and even more. The problem is that the drug metabolizes faster in animals compared to humans, and also that the production of M1 metabolites in particular is less important, is reduced in dogs. So this means that this drug is less effective in dogs compared to humans and have a faster clearance from the body of the animal. As we can see, in dogs, the oral bioavailability of the tramadol is 65%, sorry. There is an important individual variability. The half-life, I was saying before, as a faster clearance is 1.7 hours compared to the humans, that is 5 hours. This means that we need to give at least 6-8 times during the day to have to covering the entire day of the patient, and is indicated to treat mild to moderate pain. Tramadol has been studied in dogs affected by osteoarthritis. This dog is a very simple, this study, sorry, is a very simple study. It was performed in 35 dogs with OA, in which in a crossover randomized study was administered Gabapentin, 2.2 milligram per kilo, and then tramadol for 10 days. And the animals were analyzed on the force plate analysis. We can see from the graph as compared to the placebo, tramadol basically didn't affect at all this evaluation, the vertical impulse, compared to Gabapentin that increased significantly the vertical impulse of this patient. The same situation can be observed with, the peak vertical force that was similar to the placebo in the tramadol group and increased significantly with Gabapentin. Monteiro et al. Also prove the efficacy of combining tramadol with a low dose of ketoprofen for treating osteoarthritis in dogs for 28 days. They were able to prove that combining ketoprofen with tramadol was able to reduce the dose of ketoprofen, maintaining the same efficacy as the full dose of ketoprofen at 1 milligram per kilo per day. Gabapentinoids are another class of drug very commonly used for treating central pain in human patients, and they include gabapentin and pregabalin. This class of drug were developed as a human anticonvulsant drug, but then they were found to have a very important anti-hyperalgesic effect in rodent model of central pain. Then, to this first discovery, we have, after this discovering, we had several case reports, uncontrolled human clinical studies for neuropathic pain that prove the efficacy of this drug, of gabapentin, to treat central pain, neuropathic pain. The mechanism of action of gabapentin is the binding to the voltage gate calcium channel, in particular to the half-2 delta-1 subunit, and this binding inhibits the calcium influx inside the cells. It is at nowadays the first-line treatment for chronic pain in human patients and have a very low incidence of side effects that are consisting in drowsiness, fatigue, and weight gain. The gabapentin works, the gabapentinoid work on the dorsal root ganglion, where they inhibit the anterograde traffic of the sensitive stimulation, inhibit the release of excitatory neurotransmitters in the dorsal horn, like substance P, calcitonin peptide, and glutamate, and stimulate the uptake of glutamate. It also inhibits the descending serotonergic facilitation and stimulate the descending inhibition, and there's also an anti-inflammatory action. So, as we can see, there is a very complex mechanism of action that at the end works very well for treatment of central sensitization and neuropathic pain. There are several studies in human medicine that they prove the efficacy of this drug in treatment of pain related to osteoarthritis. There are very few in veterinary medicine. There are studies, there is one study, this one for Kukanich from 2011, in which the pharmacokinetic of gabapentin has been evaluated in dogs, which proved to have an oral bioavailability of 80% and is not dose proportional, and has an hepatic metabolization and renal excretion. We can see here the comparison between 10 and 20 milligram per kilo of gabapentin. The pharmacokinetic is not very different, so seems not to be dose proportional. The Tmax is between 1.3 1.5 hours, and the half-life is between 3.25 3.41 hours. Pregabalin has also been evaluated in terms of pharmacokinetics in dogs, and these are the results of this data. Also, the oral bioavailability of pregabalin is 80%, is not dose proportional, and also pregabalin has an hepatic metabolization and renal excretion. We can see that it's very similar to gabapentin. Some study has evaluated the efficacy of gabapentin in the perioperative treatment of pain. Most of these studies didn't prove a real efficacy in the treatment of the perioperative acute pain. In my opinion, this is related to the fact that these studies evaluated just the perioperative phase. But the concept of gabapentin is to evaluate the effect of this acute phase of pain in the postoperative time. Postoperative time means 30, 60 days after treatment. Amantadine is the other drug that you have available for treatment of central pain. Is it was released on the market as an antiviral drug. It is useful for the Parkinson disease and increase the central dopamine concentration, is a potent non-competitive NMDA antagonist, and prevent and reduce the activation and upregulation of the NMDA receptor in the dorsal column. So it is useful to treat and prevent wind-up. Is effective in counteracting hyperalgesia following opioid therapy withdrawal. The pharmacokinetics of amantadine has been studied also in dogs. And this is an oral dose of 3 milligrams per kilo. About 10% is metabolized to N-methylamantadine, and as we can see, is a very adequate profile for the administration in dogs. Duncan, Lascelles, evaluated the efficacy of the amantadine in dogs affected by osteoarthritis. In particular, he evaluated 31 dogs with osteoarthritis. They were non-responsive to NSAIDs therapy. We had 0.1 milligram of meloxicam for 21 days. And then, in case they were not responsive to the treatment, amantadine was added to the meloxicam at a dose of 3 to 5 milligrams per kilo per day. The control group was with the placebo plus meloxicam. So the follow-ups were at 0, 7, 21, and 42 days. The evaluation was performed with a client-specific outcome measurements tool, so a specific questionnaire that was proposed to the owner that was investigating the life and the behavior of the patient at home, and also there was a veterinary evaluation. This study proved that the most that amantadine is effective in treating osteoarthritis pain, and this effect was visible and statistically significant only after the long-term therapy. So after 42 days, they were able to find a significant difference between placebo and amantadine group. And this is the characteristic of amantadine, but also of gabapentin. They need some time, at least 20, 30 days, to show a clear clinical benefit in the dog. There is another report about amantadine from Madden et al. In 2014, in which they use amantadine to treat the chronic pain in a dog together with meloxicam. Well, my personal experience with the use of central acting analgesic for treating pain in dogs affected by osteoarthritis is mainly related to the use of Tramadol and Gabapentin. The type of subject, patient that requires this drug is usually well defined from the beginning of the evaluation. Dogs that are having osteoarthritis since long time usually have also a central component. We should always think about that. And sometimes when the NSAIDs, as Duncan proved with the study with amantadine, when the NSAID is not working properly, we should always think that there is a central component that we need to treat rather than change the NSAIDs or thinking that is not effective or something else. So my personal experience is sometimes I use Tramadol, but recently I use more and more Gabapentin in combination with NSAIDs together since the beginning many times. After few days, 2 or 3 weeks after the beginning of the NSAIDs, in case I see that the effect of the NSAID is not the best. And usually, even when I stop the use of NSAIDs after 2 or 3 months, I keep going with the central acting drug most likely gabapentin.
Thank you, Dr. Staffieri, and I'm going to now take over and talk about future treatments for osteoarthritis pain. I'm going to start off with a few comments on the anti-NGF monoclonal antibodies. This is anti-nerve growth factor monoclonal antibody therapy. I guess firstly, the question is, what is nerve growth factor? Well, during development, it aids in the normal development of the nervous system. But in adults, its primary role is pro-nociceptive. What that means is to promote the production of noxious signals, which will be interpreted as pain. So it potentiates pain. The way it does this has been nicely described by Masataka Inamoto. But briefly, what nerve growth factor does by binding to its receptor, the TrkA receptor on sensory nerves, is firstly to sensitize the nerve, very similar to prostaglandin E2. But then that complex gets transported to the cell body, the dorsal root ganglion, and that alters transcription of various things, including receptors, you might call them pain receptors, and neurotransmitters. So not only does this nerve become sensitized because of nerve growth factor, but it becomes altered in the way it looks and functions. It has more pain receptors, produces more neurotransmitters, plays a greater role in something called neurogenic inflammation. So nerve growth factor has a dramatic effect on peripheral nerves. Numerous studies across basic and clinical science have explored the efficacy of anti-NGF monoclonal antibodies, and some early work has been published in dogs. And this graph these graphs here show you the efficacy in dogs with osteoarthritis after a single dose of an anti-NGF monoclonal antibody. And these dogs were assessed by something called the LOAD questionnaire, the Liverpool Osteoarthritis in Dogs questionnaire. You see very clear efficacy in the anti-NGF group and no sign of any efficacy in the placebo group, and a significant difference between the treated and placebo dogs. Interestingly, if you compare across different studies here, so the bottom box on each side of the screen is the study I've just presented to you, a study we published in 2015, and above that you can see comparable studies looking at non-steroidals. I say comparable, studies that use the same outcome measure. So on the left, we're looking at CVPI, on the right, we're looking at client-specific outcome measures. And what you can see here is that the delta, the difference between the treated versus placebo group in the anti-NGF studies was much greater than the delta, the difference between the non-steroidal results and placebo results in the non-steroidal studies. And this actually, so this work in dogs here matches up to what's been seen in basic science and in humans, that the efficacy of the anti-NGF therapy, and at the bottom there, one of those is tanezumab that's been looked at in humans, does appear to be greater than the efficacy with non-steroidals. So greater or at least equal efficacy to non-steroidals. So far, a very good looking safety profile with no unusual adverse events seen. I suspect that when this comes into clinical practice, and the first therapy has been recently approved, it will be used in dogs of all stages of OA. To some degree, it may replace non-steroidals, and maybe there will be some concerns around young dogs that are still developing and older dogs with neurodegenerative diseases, because remember, NGF does play a role in maintaining nerve function. The other treatment I think we should talk about are the cannabidiol type treatments, CBD type treatments. This slide sums up everything we know. We actually don't know whether there's any efficacy. We really have no idea of the safety profile. And I think what you have to remember here is that at the moment, these are considered supplements, completely unregulated. And so it's very difficult to know if you're actually getting what you're told you're getting. And on top of that, we don't know how efficacious they are. We don't know how safe they are. At the moment, I think the whole area is a quagmire of smoke and mirrors and misinformation. I do think there's a huge potential for the future. and hopefully we'll see some quality information come out that will guide us in using these types of products. So just to conclude here, I'm going to kick off with a few conclusions around an overall approach to treatment, to pharmaceutical treatment based on co-staging. So for the early co-stages, we certainly want to be looking at preventing disease or modifying risk factors. And for those early co-stages, it is totally appropriate to start off with weight optimization, exercise, non-steroidal anti-inflammatories, appropriate oral supplements. And that approach is also appropriate for the later stages, but in those later stages, we're going to add on environmental modification, assist devices, move to a multimodal drug therapy, and consider adding in physical, mechanical therapies, acupuncture. At any stage, it is appropriate to consider targeted intra-articular therapies as either a standalone or an adjunct to systemic analgesic therapy.
Well, at the end of this presentation regarding pharmaceutical treatment, what are the key messages that we should bring at home, or you should bring at home? First of all, the best evidence of clinical efficacy for treatment pain and inflammation in OA belong to the COX and non-COX inhibiting NSAIDs. There are very interesting future perspectives in the use of anti-NGF antibody strategy. For sure, what is important is how to use NSAIDs. We learn from the literature and experience that the best recommendation is for long-term administration of NSAIDs, especially with the new ones. They are safe and can be administered for a long time. There is another important message that Duncan gave, is that it's possible to reduce the dose of NSAIDs. This is something that is not very common in veterinary practice, but is very common in human practice. So to switch, instead of everyday administration, to switch at the 3-4 administration per week after long time administration continuously. Consider also, especially when the treatment with NSAIDs is not effective, to add the central acting analgesic to treat central sensitization. We should learn also to evaluate this central sensitization since the beginning of the clinical evaluation of the patient. We need always to bear also in mind that there could be possible interaction with pre-existing disease, usually, especially in dogs that are old, we can say. There are other diseases. We should always consider the disease that sometimes can limit our therapy or can change our approach to the therapy. And of course, we should consider, as we say, the effect of the OA on the entire animal. We should consider the entire animal and not just the joint. And another important key message is always involve the owner in the assessment and treatment of the OA. Because it is an important aspect, is clearly evident in the last years that the sensation, the opinion of the owner and the information that the owner can provide are very critical for the effective treatment and evaluation of our patients. So thank you very much for your attention. And do you have any question?